of the Clinical Consultation Network. Welcome, everyone. Glad to have you here. Just a couple of announcements I want to make. One is that on August 22nd, we're having the TNNAD annual conference. We've got some great speakers lined up. Going to be a lot of presentations regarding the use of technology in supporting people with intellectual and developmental disabilities, particularly telehealth as it relates to serving people with IDD. So I hope you can all join us on August 22nd for the TNNAD annual conference. That web address for TNNAD is tn-nadd.org. tn-nadd.org. And I happen to have also on the phone with us today the president of TNNAD, John Weston, is on the phone. John, is there anything else you'd like to add regarding the upcoming TNNAD conference?
We've had a lot of people that were interested in coming to the conference, so we have some really awesome speakers, and we look forward to seeing everyone there.
All right. Thank you so much. And so I was thinking about all of this over the weekend. We talked a little bit about aging last week, and I was just reflecting with Bill Feldhouse before everyone got on the phone about my grandson this past weekend asking me to do several different things with him. And I'm kind of the type of grandpa. I usually try to do most of the things my grandson asks me to do, but he does get pretty bizarre. He's been pushing the limits a little bit lately. So we went to the Renaissance Festival, and I at his request, had worn my kilt to the Renaissance Festival. It was fitting. It was the Celtic weekend, so that was all cool. But then he wanted me to get my hair painted green, which I reluctantly complied with. And then, though, after we got back from the Renaissance Festival, he asked me to do the slip and slide with him. And that was a huge mistake. That was quite painful for me. I'm still experiencing the after effects of having agreed to do the slip and slide. So that's the kind of thing, I guess, sometimes we get into when we're trying to make others happy. Sometimes we put ourselves in a real awkward position. But I'm glad today to have some guests that I think are going to give us some pretty good information about someone we've been very interested in from the Harold Jordan Center, who was discharged from there about 6 months ago. Very interesting fellow with an autism spectrum disorder. I'm not going to go into too much detail just yet, as I'll let the presenters do that. But today we have with us Esther Bledsoe, who is a behavior analyst from West Tennessee and who took over the case about 6 months ago, I guess, or so, maybe a little bit longer than that. And then we also have Rachel Karnowski. And Rachel, I'll let you tell in just a moment what your title is with Capital City, but I do know that you're very involved in setting up the programming and working with individuals who are supported by Capital City. So without further ado, I'm going to go ahead and just ask you guys to introduce yourselves a little bit. Esther, can you tell us a little bit about yourself and how you got interested in working with people, adults with intellectual and developmental disabilities?
Sure. So I'm Dr. Esther Bledsoe. I'm a behavior analyst in the West Tennessee region. I've been a BA with the state of Tennessee for like 9 years now. I've been board certified for almost 10. I actually got started. I was in college at the University of Tennessee at Martin, where I was earning my bachelor's degree in psychology, and I had the opportunity to work in a treatment center that was there for kids with autism, and I absolutely fell in love with it and just continued working with children who had been diagnosed with autism throughout grad school and throughout the time that I was earning my doctorate degree. And then the opportunity came to work in the bid system, and it just kind of naturally evolved into that. So this particular individual, I've really enjoyed getting opportunity to work with him because it kind of brings me back to my behavior analytic roots of working with individuals with autism. Rachel, you can go ahead.
That's great. One thing I wanted to respond to. You said you were from that you had attended the University of Tennessee at Martin. I think that's the first time actually that I knew that you were a UTM graduate.
Yeah, that is me. Yeah, I don't always claim the Martin side of it. Sometimes I just claim the but yeah, I was a university scholar when I was there, so I had part of that program was completing an undergraduate thesis, and so I did my undergraduate thesis on the causes of autism back in the day. So it's a pretty good journey. Yeah.
Excellent. Very fitting. Okay, so also with us today is Rachel Karnowski, who I spoke of just a moment ago. Rachel, can you tell us a little bit about yourself?
Hi, I'm Rachel Karnowski. I'm the Vice President of Capital City Residential Healthcare. I started out in the field actually when I was 14, working in a nursing home, driving my mini bike, kind of continuing through there through journeys to the mentally ill group homes and State Board of Health surveyor. And I've been with Capital City the last 15 years now. So my specialty has always been with folks with extreme kind of behavioral difficulties. And I have a degree in psychology and, in history.
Yeah. What was the reference to the mini bike?
Oh, well, I grew up in the country, Mr. Bruce, so I had to ride my 50 Yamaha CC mini scooter to work in the nursing home, 14 miles, because they paid $3 an hour compared to working on the farms, which paid $2. So that was my big intro to the field.
All right, that's great. So everybody's got a different background. That's a really good story. All right, well, I appreciate you guys coming on today. And by the way, my co-host today is Michelle Bagby. So, Michelle, you want to say hello to everybody?
Hello, everybody.
Oh, Michelle is so enthused about saying hello to everyone this morning. All right, well, so you guys have got an interesting case today that you want to discuss with us, and I think there'll be a lot of interest in this. This was a fellow who was served at the Harold Jordan Center, and as I mentioned in the little advertisement that I did for this a little bit earlier today, he had been somebody who had periodically had pretty severe aggressive behavior. He was presumed to, at that time at least, to have some of the symptoms of bipolar disorder, and so this tended to occur kind of on a cyclical basis for him, although I think there were other factors besides the bipolar disorder that may have caused him to have these cyclical outbursts of problem behavior. And so we've been struggling for some time to help him be successful. And I think we're interested a little bit today in getting kind of an update on where we are, what kinds of accomplishments may have been made, or what kind of ground we still have to cover to help him be optimally successful in the community. So maybe I could just ask one of you to start out by giving us a little thumbnail sketch of his case and some of the relevant parameters of that. So who will start that? Esther, is that you?
I can do that, yeah. I can do that, Rachel. If you want to jump in with any other information, but I kind of wrote down just a couple of notes just to generally give everybody a picture of him. So please jump in, Rachel, as needed. So everybody knows, Rachel and I work really closely together with a lot of the individuals that I have with Capital City, and so this particular case, she and I have, I feel like we've been pretty well tag teaming. She tends to know a little bit more about the day-to-day things that go on, and so she'll please jump in, like I said, at any time. So this individual is 22. He loves his toys and his music. So he loves blocks and cars and airplanes. He loves listening to music of any kind, and he also really likes pizza and ranch dressing. I feel like that's pretty much a good picture of anything that, if you want to please him, any of those things are great. He is diagnosed with pervasive developmental disorder, impulse control disorder, infantile autism with selective mutism, and intermittent explosive disorder. So when we did the behavior assessment, when he first came to Capital City, the biggest one of his problem behaviors is that we've really been focusing on is the property destruction. And we have found that those are more likely to occur when people that he is unfamiliar with or that he feels like maybe don't know him as well will see an increase in the property destruction. And also, if he's trying to communicate something to us and we don't understand, then he tends to get a little more frustrated. He very much likes routine, so things have to kind of happen the same way every time. And Rachel, you can explain this a little better, but if something gets off on that routine, you have to kind of start over at the beginning. So I think the example
let me ask just a quick clarifying question about the property destruction that you're talking about. Can you describe like some of the
intensity?
A little bit about the intensity and just what's actually happening when he does that.
Yeah, so when he engages in property destruction, it's not just like a hole in the wall. It is, if I punch a hole in the wall, the whole entire wall is going to come down. Or if I break off part of the threshold around the door, then all of those pieces have to come down. There was one day a couple weeks ago that he had broken, was it the light, the actual light bulb in the ceiling, so then all the light bulbs had to be the same.
I think the most interesting part was the ceiling vents, like where your air conditioning comes down. There were 7 of them in the house, one of them behind a locked door. Nothing was going to do till all 7 of them came out of the ceiling.
Okay.
You know,
it's one of those completest things. Got to get them all.
Right. So he has to complete the cycle, and with whatever it is, and any kind of, and part of I think what we've learned with him since he's come is that he has to go full cycle. Like, had we realized in time what he was doing, we probably would have just unlocked the door and let him take the last one out.
Right. Go ahead.
Go ahead, Dr.
I was just going to say, when he first came to the house, there was padding on the wall, and when he realized that padding could come down, it was every single piece of padding in the house had to be removed, or so it almost gets to the point. I've talked with Michelle about this a little bit, where it almost ends up not being as much property destruction and more like it starts off as property destruction, but then it ends up more as like almost an OCD component where he has to finish the job. So he might not be engaging in property destruction anymore. He might not be quote unquote agitated, but I knocked a hole in the wall, and now I have to take down all the rest of the pieces. Or I tore off some of the padding, so now all the padding has to come down, even though he might not technically be engaging in property destruction at that point, if that makes sense.
Yeah. I can share a story from when he was at Harold Jordan Center where something similar had happened because I had some protective equipment that I was wearing under that circumstance, and he had kind of gotten a hold of some of that protective equipment and started to sort of tear it off of me. And once that process got started, the incident was not going to be over until it was completely torn off of me. And that's part of the reason I shared that story about putting myself physically at risk earlier with my grandson, was because that was actually probably one of the most physically taxing circumstances I had ever been in, where I was trying to block and redirect his behavior during one of these episodes. But I don't hear you mentioning much about physical aggression. So is that a problem that is at this juncture kind of gotten under control, or is it still emerging from time to time?
Well, what we have seen is the physical aggression occurs if we are too close to him when we can't solve whatever the problem is. So, or if he's trying to get you to solve the problem and you aren't engaging him in a way where he feels like you're trying. So for the most part, if the agitation is escalated to the point where, like, the property destruction is occurring, if we're far enough back, he doesn't come anywhere near us to attack us. If you're too close to him is when the attack will happen. And if he does, like, grab you or try to hit you or headbutt you or bite you, the further you can get back, the faster. He's not chasing you for that aggression to occur. You know,
okay.
So even if he does strike out on you, the further you can get away where he doesn't feel threatened is what I think it is. You know, that pretty much stops. Now, he will, if he's trying to communicate something or he needs something fixed, you know, and he feels like you're not, you know, you move back too far where you're not engaging with him, you know, to try to figure out the problem, you know, that can also cause that response. But we have found that he's oddly patient in some things. I'll give you an example. On a weekend, they didn't realize they'd run out of his ranch dressing. So you understand he has 2 cups of ranch dressing, same cups every meal. And, you know, it looked like there was ranch in the bottom. There wasn't. And he was getting loud and starting to escalate. And they called me. And I said, tell him I'm going to bring him some ranch, you know, to hold on. And they did. And he waited for 25 minutes for me to stop at the store and bring him some ranch. And he was completely calm because he knew that the problem was going to be solved. So, you know, what we're finding is that his tolerance for not having those things, if he's with people or he understands that it's going to be resolved, he has some ability to wait and to be patient. So a lot of what we've worked on with this staff is how do we communicate? Okay, we know what the problem is, and this is what's being done to solve the problem.
Right.
Yeah.
And part of that cycle with Rachel, and you can explain this some more because I just don't do a good job of this, is that he has a certain routine when he's eating. And so with that episode with the ranch, he had to start over his entire eating routine with the juice and all that. Can you explain that a little bit? Do you know what I'm talking about?
Yeah, so for him, what I discovered is that the process on anything, whether it's him getting changed or the meal, if you mess something up, you have to bring everything back and start over. So in this case, you know, they had, with the ranch dressing, they had already brought him his plate and his cup and everything a certain way, but I couldn't just bring the cups of ranch in now. I had to bring everything back and start over anew. And I've had some things with him where, you know, he didn't want one part where it was on his plate, but he wanted the other part. And what we were trying to do was, you know, fix it at that moment, but he has to start over. Even if one person's glove rips when he's getting changed, because everybody has to wear gloves when we change, you know, everybody has to take theirs off and throw them out and bring everything back and then start over so that the whole process goes right.
Okay, yeah, so that's very consistent with some of the things we saw there at Harold Jordan Center with respect to his need for routine, especially in those changing routines. It did seem like they changed, some of the expectations on his part changed from time to time, and, you know, where you had to learn new information or something additional that might be important to him in those processes. But I do agree with you that it seems like figuring out those routines is one of the key things with him. Let's see. I just want to ask about one other target behavior, self-injurious behavior, because you would have that from time to time as well. How has that been going? What have there been any injuries to self?
Yeah, his head is completely healed up now. So in the beginning, when he was first transitioning, with it, more of our injury was coming with the tearing down of stuff. You know, I ripped off a piece of the door frame and it scratched my arm. You know, I broke the toilet, you know, and I got a cut on my hand.
I knocked out the window, and it busted on myself, Yeah,
so initially we saw a little bit of like the biting and stuff, but we really haven't seen much of that the last few months, you know, with the self-abusive type behavior.
Okay.
So,
excellent. So I've interrupted you guys enough here. I'll let you take off. Go ahead. I'm sorry.
Go ahead, Rachel.
Go ahead, Rachel.
Oh, okay. Well, you were talking, Dr. Bruce, about like the changing of the routines. We had when he first came, you know, he takes syrup on his breakfast stuff. And when he first came, when I was doing breakfast with him, he took the cap off and he licked it and he threw it in the trash. Well, sometime over the course of a couple weekends, that had changed, where he was wanting staff to now take the cap off and pour it on and throw it out. So, you know, that change in routine, one of the important things we have to do within the agency is communicate, because he was highly upset at me because I wasn't taking the cap off the syrup and putting it in the trash can because I hadn't done breakfast with him. You know what I mean? So that part had changed. So one of the things we have to do constantly is make sure that when he's made an adjustment to how he'd like things done, that we communicate that to everybody.
And you know, that was, I think, one of the most frustrating things, because sometimes it would take a while to even discover it, what it was that you might be doing wrong, so to speak, and then ultimately making sure that everybody knows about it once you do find that out. Very key thing. So that's very good information. So yeah, go ahead and explain a little bit more about. Go ahead.
I'm sorry, Chris. I forgot one thing. When we were talking about the proper instruction, talked about the importance of allowing him the time to finish whatever it is that he's doing. I forgot one of the most important things. You also have to allow him the opportunity to try and restore what it is that he messed up. So I learned this the hard way, and this is one of the things that Rachel was talking about with communication. That's been the biggest key, I think, in his success. And then just kind of learning things on your own at times. He had gotten into one of the rooms and had messed up the wall to where there was some piping that had come down, or it was some pieces of metal. And when I was, what'd you say? I'm sorry.
It was a piece of the closet bar.
Yes, thank you.
Or something.
I was over there talking with the staff and just looking at different things, and I picked up and moved a piece of the metal. Well, that was not something that I should have done at that point, because, hold on one second. I'm sorry, being a mom does not stop. I picked up the piece of metal and moved it, and the staff was very adamant that that was not, I should not have done that, because he would know that it had been moved, and then it would mess up his opportunity to fix it and make things right. So thankfully the staff that was there that day was able to kind of keep things under control. But I forgot that piece is one of the most important things, is not only allowing him to complete what it is he destroyed, but also allow him to attempt to restore it in his own way.
I think that's been one of the biggest keys to our success that maybe wasn't possible at the Air Jordan. Because, you know, the way Mikey takes down a door or a frame, this gentleman takes down a door or a frame, it all comes apart in pieces, and like he said, he tries to pick them up, and he will literally sit there for hours restoring his environment, and picking up the pieces on him can cause an extreme escalation that was greater than the one that broke it down. So really allowing him, if it takes him 6 or 8 hours, we have to wait for him to be comfortable with the way that he's put it back together and go to sleep for a good while before we can pick any of those pieces up. And this is so intense with him. He had broken off the cover to the thermostat, and we just left it on the floor because we knew we couldn't pick it up until we had a chance to pick it up. And our maintenance man went to pick it up, and we, tried to stop him. And Mikey was close by, and he ended up headbutting our home manager. And, because somebody was trying to move those pieces. I just tried to make sure the home manager was okay, because that instant, that quick fire, if something was wrong was super important, is really intense.
Yeah, so one of the things I was going to mention about this too is it sounds like you guys have kind of reconciled yourselves to the idea that you're going to have to make pretty significant accommodations for him. It's, I think where we were kind of trying to test the waters a little bit some at Harold Jordan Center was in teaching him to tolerate these things better, to kind of be able to get through them a little bit better. And truthfully, I think it was a good test because ultimately I think you're right in his circumstance, the benefits of trying to teach tolerance in these circumstances probably are outweighed by the risks associated with it. And that in many ways it is trying to figure him out more than kind of causing him to try to figure out a way to help him adapt to these changing circumstances and differences in routine and so on. So it seems like that's one major thing that you have arrived at with this.
What have you, sorry guys, this is Matt at the Harold Jordan Center. What have you guys done in the way of like replacement behaviors with MP? One of the things we did with him was, you know, as you discovered, he likes to deconstruct things to almost a microscopic level. And one of the, just for example, one of the activities that we found some success with that kind of put his property destructions aside was we got him one of these knitted blankets. And he would pull every single string out of this knitted blanket, right? And it would keep him busy and kind of satisfy that OCD urge that he's got. So I was just wondering what you guys think.
If I can speak to that a little bit with even the destruction and the re-putting back his things, what we do is we found out that he really likes wood manipulatives or toys or whatever you want to call them. So having access to those interchanging frequently enough gives him something. You guys know what Jenga is, the block game that you stack up and try to pull pieces out?
Yeah.
We got him sets of those, and he built them up exactly as they came out of the box, and deconstructed them and reconstructed them at every possible formation. So what, you know, his need to put together complex things is pretty high, so we try to find those type of opportunities. And the truth is, as far as managing his frustration, I think now that he's learned that we're not going to intercede with the way he's handling that, we actually, what he does a lot now, instead of destroying stuff, is he will lay on the floor and cry and spin around but not destroy stuff. So we think he's working harder to manage that frustration now that I think he's more confident in what our response to it is. And, you know, I don't know if Mr. Weston's on the phone. What we really settled ourselves with is, as we figured this out, we knew we were going to pay a high dollar amount for property destruction and reforming this and retrying that. And, you know, I mean, the truth is thankfully he's at a place where, you know, the administration is committed to that kind of investment. And how do we figure out and how do we fix that? And, you know, the other thing that's big, of course, with everything is communication. And he's talking more. He's using more words. He's saying phrases like, I need. His parents came to visit this past weekend, and he was saying things like, wow. And, you know, so we've seen a lot of increased attempts for not only his showing you what it is and trying to find you, but even his verbal communication now that he's gotten more comfortable. So we're continuing, and we're actually getting ready to start trying to see if he can interact with his parents through FaceTime.
All right.
Yeah,
that sounds pretty awesome.
That's
for
one
the short
thing.
term.
I was just going to say.
So let me just mention this, right, Dr. Bledsoe, and then I'll let you react. The thing I want to point out, okay, so it sounds like you're working on both sides of it. In some sense, you're still accommodating, trying to kind of deal with some of his preferences and so forth, and then also trying to work at the same time to help him learn deconstructing skills with Jenga or communication that will help him, you know, maybe eventually be able to maneuver a little more easily through some of these difficult circumstances and maybe even express more about what he needs under those circumstances. So that seems really, really important in this case to me. And so, Dr. Bledsoe, I'll let you go ahead and make the point you were going to make as well.
I'm sorry. I was just going to say, I think that's been probably the biggest key to the success that we've seen so far with him has been just the willingness of Capital City to think outside the box and to think of ways that we can approach and find solutions to a lot of the issues that we're seeing, because a lot of times it does cost a lot of money. There has been a huge amount of property destruction in that home, especially in the beginning. But they've really been able to. It's been kind of fun almost to figure out, well, how can we solve this problem, in a different type of way. I was also going to say, speaking to some of that replacement behavior stuff, I know Rachel was talking about the different toys, but they also do a really good job of bringing new toys in and cycling those toys kind of in and out so that he doesn't have the opportunity to get bored with those skills. So, there's always opportunities for bringing in different items. Rachel often just bring them to the house, and the staff can introduce them as needed to kind of ease some of that, well, I've already played with this, 500 times, and then it leads to more problem behaviors. So that's been another, I think, real key to success.
So building in some level of choice and maybe adding things that he could kind of shift into to take upon different interests is something else that you're working with. Correct. In this case.
Exactly.
Yeah. Yes. That's great. Okay, so just as it relates to the property damage, I mean, I know how extensive that can be. I'm just trying to get a read on exactly how difficult that part has been. Is it at a manageable level right now? Is it still at a level where it's really got to come down in order to be able to successfully support him? Maybe anything you could give us to characterize that a little bit would be helpful.
Well, one of the things I think that we had to learn is how he destroyed stuff so that we could put things. And one of the things we discovered in this is his extreme love of wood. I mean, not just wood toys, pieces of wood, things that put together. So when we had to, reinforce the fall with wood, besides watching us work, once you had a structurally sound piece of wood up on the wall, then he doesn't mess with it. But if he looks at it and doesn't think it's structurally sound, like let's say it has a little flex in it, that's when he tries to tear it down. So for the most part, once we've got the environment, so his place looks a little different than most, but he likes the wood feel everywhere. And once it's structurally sound, he has a tendency not to go to that spot again. So we've probably gotten better at figuring out what that is, but I think he's a better engineer than we are.
Right.
And like we did some stuff like, he likes to hit the windows. So in his room, we basically set the plexiglass where if he hit it hard enough, it popped out, but it didn't break. Now it's the super thick lucite type, and once he popped them out a couple of times, he didn't pop them out as often because they weren't breaking. And, so I think part of it is the more secure he feels that it's secure, the less that he has a tendency to target it or mess with it.
Yeah, it's all been about setting up that environment in a way that it almost prevents it from occurring. So, like Rachel was saying, if you just put the piece of wood back up, or like there has been some issues with him wanting to break the toilet. Well, if you put the same toilet back in, but with like a new toilet seat or something on it, that's not good enough. He will work to destroy that again. So it's almost setting up the environment to where it's not that he can't break the things, but where he won't be as likely to break the things because, like Rachel was saying, he feels more secure and he realizes, oh, well, this isn't going to break, or, I don't want to break something that's good or looks good or whatever it is that he's thinking.
He doesn't like anything to stick out from the wall, not trim, not light, not any of those things. So getting everything to where it's smooth and not sticking out has been a big thing, too. The other thing we discovered, he still has the special bed that came from the Harold Jordan Center, but he likes to be cuddled up in the corner. So of all the different things he's tried to break in the house, the walls that are where his bed is in the corner, he's never touched because he doesn't want that bed to be moved.
Interesting.
So he has, So pretty
I can endorse what you're saying about, when there's something hanging or something that's a little bit separated, that those are things that for him are very difficult to tolerate, and it seems like those will be items that he'll go for. But if you can create a circumstance where that's a solid, a solid structure of some kind, in his case, I think one of the benefits at Harold Jordan Center was the fact we had concrete walls, and rarely did those ever, you didn't kick the concrete walls because they weren't going to break. They were solid structure, and so seems like you're kind of learning that same thing with him. So, all right, well that's very interesting. What else? Any other parameters in this case that are interesting?
Well, some of the other things I can add to the interest is, it took us a minute to get him in the shower consistently, and what it came down to was playing a shower song that's on YouTube. And now you play the song, he knows it's for getting ready to take the shower, and he's great. So, finding how we can get him indicators and with something that he enjoys has been huge.
He's getting in the shower and with the water spraying on him and all of that.
Yeah.
Okay.
And
excellent.
Yeah.
So you kind of got a little bit of a routine going with him on the showers that has kind of just become part of the way he does things, and so as a result of that, he's participating a lot better, it sounds like.
Right.
And one of the things I wanted to mention from a little bit earlier, because we were talking about changing, and I'm not sure it was clear to everybody that he requires changing on a regular basis. Like changing his clothing, his adult brief.
And that's definitely a multi-stage process that you have to do right. But as you've gotten, it's important that you're taught the right way on how that goes. And so he has to have, everybody have their gloves out. He has a bag he puts his dirty clothes in, and you have to have the right depends and the right, wipes and all that stuff. But what we
and the right
found
bag, people. The right bag.
Right. The right bag is a big deal. But what we have found to me that's most interesting is when I'm training staff on that process, sometimes he doesn't want new staff to even come back for him to change. He'd prefer that, he change, with like just me. And then then the next change, he wants them to come watch, but not participate. And then by the third change, then he wants them, and it's okay, then he gives them gloves to put on and participate. So it's been very,
that's a great observation right there, that, that helping him adapt to new staff and finding a process for that to occur, I think that is critical. I think it is something that is often and creates a lot of problems, but I do think that's probably one characteristic for many people with autism spectrum disorders that you're not going to overcome, is that difficulty adapting to new staff, and having found a combination for making that work is really, really helpful and impressive.
Yeah. And I think a lot of the thing is that, kind of respecting or listening to what's going to work for me. And, he's very smart. He understands everything that you say. And if he's not ready for a new person to participate in an activity with him, it's gotten to the, we keep, like, his depends and stuff in the kitchen. He'll just walk that person back to the kitchen like, no, I don't want you here right now. And even me, as much as he likes me, if I brought him a new activity to engage in, and one of the first times we got him to say goodbye was he was walking me out, and I just brought him something new. And I said, okay, if you want me to leave, tell me goodbye, and I'll leave. And he said, bye-bye.
That's great. That's great.
Because other times he wants me to stay with him, but I think, part of that picking up on is he will rearrange his people and his staff and what he wants if you allow him the opportunity to. and you recognize that's what he's doing.
Oh, man, I love that. Okay, I'm going to open it up to some of the other folks on the line, especially those folks at Harold Jordan Center who may be listening in. I know we heard from Matt just a moment ago, but if anybody else wants to ask a question, please jump in and do that now to kind of see and maybe share any information that you may have that would be helpful to Dr. Bledsoe and Rachel.
So this is Matt again. There's just a couple of us in here, but I guess it's good. Everything I'm hearing is awesome, and I'm glad that he found himself with you guys and you're experimenting with the environment. One thing I was wondering that we didn't get enough time, as I had hoped here, to sort of investigate this, but when he was having self-injurious behavior, we sort of hypothesized that it might have something to do with his teeth or the condition of his teeth. And I was wondering if you guys were having any more luck with compliance at dentist appointments and doctor's appointments and stuff like that.
Well, I'll tell you the two things. We have doctors that come to the house. We have. It took us a while when he first came to tolerate the toothbrushing. But he is doing so much better than that. But it took us a couple of months to get good toothbrushing and getting him to spit out when he brushed his teeth.
Yeah.
So to be honest with you, what happened is our home manager started brushing his teeth with him every day. Like, here's what we're going to do. So home manager brushing his teeth, Mikey brushing his teeth. So we've gotten to the point where he'll let us brush them. And help him now, but only if, at first the home manager had to brush his teeth every time.
Right.
And he could roam out of that. We're still having some issues. He would not leave the house. We had our first successful trip out of the house this past weekend. He wouldn't take his shoes to go out or his coat. And we really think that with some uncertainty about where was he going.
Right.
And when was he... and so we were able, to get that done. So he's, trying to get him to understand this is where he lives now. You're not going anywhere else. And when his parents came down, your parents know where you are, And so we finally had some success with that. But that was a big challenge coming up.
Yeah. He would get to the point where he would say, okay, we're going to go for a ride. Let's go to the car. And he would walk to the door and then just put his shoes down and sit down, and he would not budge. So I'm glad to hear. I was telling Michelle earlier I wasn't sure if there was actual success over the weekend or not because with the holiday I hadn't heard. So, yay, that's great news. I know it's been that's been the biggest struggle.
And the biggest fear was once we got him out, could we get him back in the house? Which
Right.
He came home and went, he came home and got out of the car, took my hand, and walked back in the house.
See, that's awesome. We always had a little bit of trouble. Once he was in the van, he just wanted to stay in the van for the rest of his life.
Yeah. Well, that's why it was so... I was just going to say that's why it was so surprising that he wouldn't go. Like, that's truly why he wouldn't leave the house. We were like, we know based on what you guys have reported that he loves to be in the van, and he would not get in the car. So, yeah.
Now that you've broken in on that, hopefully that can kind of, you can build on that success that you've had there and keep that going. A couple of questions I wanted to ask just kind of in the background. So has he had any medication changes over the course of the time that he's been with you guys?
They put him on Klonopin 0.5 twice a day, and that seems to have helped.
It helped in what way?
Like his agitation level. His quickness to be agitated. Like we saw, it's always hard to rule out if it's getting more comfortable in your environment, or the medication. But, it seemed to, help. The other thing that happened is, go ahead, Dr. Usher.
I was just going to say this is not a clinical way of saying it, but it has taken the edge off. It's the best way that I can describe it so that everybody understands. Like it's made it to where I think he's able to tolerate some things a little better that he wouldn't have, that he wasn't able to tolerate as much before.
This is Stephen Bell. Is the only medication he's on the anxiolytic, the anti-anxiety medicine, or is he on something else also?
He's only on Depakote and Klonopin as far as those type of drugs. The other thing that we've added, is we think that, there's always some concern if he had pain or headaches. There's PRNs like Tylenol and Advil, and we also think that a big part of it has been managing his constipation a little better. I don't think he was at near-death rate or anything, when he came, but his belly is more supple, and his participation with us, and his mood is better the more supple his belly is. So we have worked hard to make sure that his constipation is very, very well under control, because the better that is, the better he is.
Does he have any other physical problems?
What's the Depakote?
That's for mood
Go
disorder.
ahead and answer Stephen's question. Does he have any more physical problems besides constipation?
Yeah, we think when we first hit off that green pollen, that he might have been having some headache or pain issues, because when you spend time with him, he doesn't seem the same, and you would ask him if he was hurting and give him some Tylenol, and you see some improvement. So,
I'm so glad you brought this up, because
I knew you would like to see us talk about it.
well, of course, I always love any good food story. That's just,
Well, he would be more available.
Yeah, right. But the point I want to make about that, I was talking about how, alternative hypotheses for why this stuff goes in a cyclical fashion, like it does sometimes, is the idea that it's physical, that there's something physiological that's going on with him that is creating, some sort of discomfort or pain that may sort of be a stimulus for him to go into some of these other sort of weird coping ways of coping with that difficulty that he's having. And I think a lot of times, because physiological conditions, particularly one like constipation, or even, the consideration of things that are moving slowly or obstructing his bowel, could be things that are causing enough physiological distress that his ability to cope with things he might otherwise deal with are reduced. The other thing is that there tended to be kind of a drift that occurred in people carrying out the things that had been helpful with him, like keeping him on a steady routine and making sure that things went very similarly from one day to the next. When that dropped off, there were typically more problems. I am surprised that you didn't have mood disorder listed as one of the diagnoses, because I think I could be mistaken, but I thought he did leave Harold Jordan Center with that diagnosis, and that explains why he's on the Depakote currently. So that might be something you want to take a look at.
Yeah, I'll get that.
Let me just ask on the part of anybody else on the phone, or any other questions you guys would like to ask, or my co-host Michelle, is there anything you'd like to ask?
I was just going to say, I don't really have a question, but I did want to commend Rachel and Esther and pretty much the whole team out there for really taking the time to have patience with him and understand the purpose behind some of those behaviors, and accepting the risk of allowing him to get through and complete his cycles of whatever he's trying to fix. I think that's great that you guys have been able to kind of allow that, but also teach him some of the new skills and routines, and just be patient with doing that at his pace. I think that's great.
Thank you.
Yeah, I can't say enough about the stick-to-itiveness that you guys have had with this, and especially, given that I know how difficult it can be sometimes to, especially from the financial perspective, to continue working through these. So, that part of it I certainly want to commend as well. Other questions, comments?
Well, this is Jana Dreisner, and I was just wondering if there were any other medications tried in the past, and especially around, I didn't hear any diagnosis around the obsessiveness that you were describing, obsessive compulsive, and it seems like there's enough there that extends beyond what would just be attributed to autism. So I was wondering if there was any medications that were addressing that.
That is an excellent question, and I cannot recall specifically. I should have reviewed the record before we came in here today. I cannot recall specifically if that was tried. However, my recollection is that it was. And so what we find with people with autism spectrum disorders is, sometimes when they have this OCD response, it is really OCD, and other times it's more related to more repetitive behavior that they engage in, and that sometimes it's not treatable with some of the typical medications that would be used to treat that. But it's certainly worth consideration. I think what we should do is ensure that we have had some trials of that, at least to make sure that you folks at Capital City are aware of those trials that have occurred in the past, if I am correct in what I'm saying, and to, be able to make sure your psychiatrist knows about that. That's a very good thought. Thank you for bringing that up, Dr. Dreisner.
And Dr. Bruce, I could add a little something about what we discovered about his sensory input things is, we've seen a lot of tactile sensory need from writing the scripts that come off to the pens to even breaking stuff when he's in frustration. It's all hand sensory issues, and also sensitivity to bright light. So I think that's, we are in a lot of darkness, or low light in the house a lot, and that helps a lot. And I think that finding the right kind of tactile manipulative for him, that sensory need for his hand, especially to manage frustration, has been significant as progress.
No, that's a great point. There's so many things. Yeah, there's so many things about this case that are interesting to delve into, and what you're bringing up, the sensory concerns, is one of the hugest. And this was another thing. I can remember in the early days when I was working with him, I thought, man, I've got this thing figured out, because I was seeing that he liked wearing like nylon slacks, and he was gravitating back toward this same pair of nylon slacks, no matter what you bring into him. And if you brought him something besides those would get ripped up, and then you have to kind of cycle back till you got to the nylon slacks again. And so I thought at that point, wow, okay, so we've really discovered something. But that tended to change also. It wasn't like once his preference with regard to sensory that was always his preference. And
part of what we're learning. I'm sorry, Dr.
No, I was just going to say, the other discovery that's really good is that his sensitivity to light. That's a good discovery that you made there.
Well, and the other thing we discovered with the clothes thing is it's not always what it is, it's what color it is. Like he won't wear a white t-shirt even though he's down with 10 of them, and I saw them at the Harold Jordan, with him on. But what he really prefers is blue, black, gray, nothing bright. And, he looks at the tag on how to put a shirt on, but he's gotten so used to the rooms and the haze that he had up there that it's very rare for us to get a different brand on him, because we're not sure if he can read or not. But even if it looks the same, right color, printing on the inside of that tag is not right. If you try a different brand. So we're finding that color makes a huge difference. And even with his socks, what we discovered, he has a size 14.5 shoe. So when we switched to the big man socks, the ones for that made a huge difference too, because he was putting on socks, but he thought they were too small. He was still putting them on, but when we switched them to the larger size socks, we find more peacefulness, you know. So,
Excellent.
we added this.
Yeah.
And now, when we see an increase in clothes tearing, that's normally because he's managing frustration instead of tearing down the wall, or because, they have been washed enough they don't feel the same as a new pair.
Well, that is excellent. And I hope you're recording all this information about his preferences, because I think that is clearly something that you want to be gathering information about and, planning for going down the future. I mean, like I said, there's always the possibility that those things will change, but nonetheless, if you're not paying attention to those things, it may be something that is creating more problems for him and you as well. So I just wanted to, if we come to the end of our time frame, we could probably go on for another hour on this case. I probably would like to ask if you guys don't mind coming back at some point and maybe updating us a little bit more on how this gentleman is doing, and any new discoveries that you've made. Would y'all agree to do that at some later point?
Oh, yeah, sure.
Yeah, that's great. I appreciate it. So, guys, I really appreciate you having participated in this today. It has been excellent, and I want to encourage you and everybody else on the phone to come back and join us every Tuesday at 1:30 p.m. Central Time for the Clinical Consultation Network. It's a place you can kind of come just to learn a little bit more about how to maybe approach some of the cases that you're dealing with on a daily basis, and also maybe to contribute some information that would help someone else. So I really appreciate you all being here. Appreciate everyone on the phone, and we will see you again next week at 1:30 p.m. for the Clinical Consultation Network.